Thank you very much for your very kind introduction. Thank you for your very kind invitation to both Visalama brothers and David Garber. I come from Sardinia, which is this big island in the middle of the Mediterranean Sea, and I do love pedaling my sea kayak. This is the town the place where I live on the south coast. It's called Cagliari. And I have my practice and my teaching center as well, based on the biomimetic dentistry. So our starting point about biomimetic dentistry is based on some mottos that I've been introducing over the years. There is no aesthetics without functional and gingival health. The more structurally compromised tooth, the more conservative we need to be. And then biomimetic dentistry is not just using a biomimetic material, but using that material according to a biomimetic protocol. So this is what we usually start from. And this is the Deli-Peri protocol. This is just a graph. You can find some more information on my website. By using stress-reduced direct composite restoration, we can complete the restoration of medium-size restoration, direct cusp replacing on both vital and vital teeth. We can also manage the fracture of the cusp when the periodontium is involved, and we can also complete a full mouth rehabilitation with stress-reduced composite. Okay, so what are the goals of biomimetic dentistry? First of all is the conservation of both sound structure and pulp vitality. Then we want to avoid the formation of secondary caries, reproduce the shade and texture of the natural dentition, mimic the micro movement of natural teeth during function, and avoiding catastrophic failures from masticatory crushing forces. So a stress-reduced direct composite restoration has the goal to maximize the bond and minimize the stress coming from both polymerization shrinkage and occlusal stress. And we want to mimic the performance characteristic of a natural dentition. Also, porcelain veneers, feldspathic porcelain veneers are a biomimetic material that we need to use according to a biomimetic protocol. Isolation, real isolation with rubber dam is one of the key factors for long-term success. And we will go through that. Sometimes we are able to combine porcelain veneers, feldspathic, with direct composite veneers in order to achieve a good result to restore the worn dentition. And if you look at this picture with the polarized light, you will see a very good match between the feldspathic porcelain and the composite veneers if your layering protocol is correct. So we do need guidelines to achieve a good result, and we need a step-by-step protocol that was published in the literature whenever you use porcelain or composite in the anterior or posterior area. And the starting point is the analysis of occlusion and the opposite dentition, then the cavity prep and the caries removal endpoint, the analysis of residual tooth structure. Step number 4 is the preparation of the dental substrate to achieve a reliable bond to both enamel and dentin. Step number 5 is the control of the stress from polymerization shrinkage by using sophisticated layering and curing techniques. And last step is the occlusal force equilibration. So we start with occlusion and we finish with occlusion. You can find these detailed guidelines in the publication in the literature. So if we want to go in the anterior area first, we need to focus now on the layering technique. So the aesthetic outcome when performing a direct composite restoration, stress reduced in the anterior area, is based on the combination of the final form of restoration, which is the most important thing. Then we need to select the color and a correct layering technique for both the dentin and enamel shades. So this is a patient that came to my office because he wanted to improve his aesthetics and, of course, he needs to have some orthodontic. He is very picky, but he doesn't want to do any periodontal surgery, okay? So we planned to do a treatment plan with the orthodontist in order to achieve a good result, to match the gingival level of tooth number 9 with the gingival level of tooth number 8. And this is the final result after the orthodontic treatment was completed. So the intrusion of this tooth number 9, allowed equal gingival level of the two centrals. Now it's the time for me in order to understand what the patient is expecting to achieve. So now I'm trying to have into my mind the idea of the final restoration, okay? Now the next step is to transfer from my brain to my hand the final result through a quick direct composite mock-up that the patient can see the same day that he has removed the brackets in the upper teeth. So now I can go ahead with the final restoration, which is mainly an addition of a composite on the tooth structure, and this is the result at the 1 week recall. So now I can see that the color match is pretty good, and I can finalize my case by using some burrs and a polish system in order to create some macro and micro texture on the tooth in order to match perfectly the texture of the adjacent teeth. And this is the result after 2 weeks. So now we are able to perfectly mimic the adjacent tooth. This is where we started from after the orthodontic therapy, and this is the final result. And the patient smile. So we need to complete some additive composite direct restoration via an ortho-perio approach. So minimally invasive. I would like to introduce you Valentina. She's a model. She works on radio and TV shows, and she's also an archaeologist. She looks very good, but she came to me because she has a problem. When she smiles, she has this big diastema between the two central teeth, and she referred to me that she had some dental work done in the past, but the occlusion was wrong, and these two teeth moved apart. And you can see that now we have a flat papilla between these two teeth, okay? So we started studying the case with the orthodontist, and the original idea was to move the teeth in order to close the diastema and then complete the restorative section with some porcelain veneers. We were almost ready to discuss the case with her, but she called the office and she told me, you know what, I have good news. I got a job and I'm starting next week. So, good news for her, bad news for me, because now I needed to fix the problem right away. So I let her come to the office and start playing with the composite, trying to see if I could complete a good restoration by completing two direct composite veneer. She was happy with the mock-up that we did complete, so we go ahead and complete the restoration by using direct composite restorations in order to close the diastema and match the final shape and color that was tested with the mock-up procedure. So this is the final result, and as you can see, we have now a very nice papilla that was recreated between the two teeth by creating a correct emergence profile of the composite veneers. A close-up view of her smile. She was very happy of the result that we achieved. But then she called again the office and she told me, you know what, I would like to have my teeth bleached. And you know that this is not the right time, so I let her come and I tried to selectively bleach some of her teeth, mainly the canines, and we were able to achieve a good result without changing the layering of the composite restoration. And here is the final result. The close-up view, and the teeth at the rest position when she's working. So in this case, we were able to manage everything, including the papilla shape, with direct composite restoration. One visit, direct composite restoration. What about this patient? She's complaining, of course, for her smile, which is not very attractive. So we are planning to complete a treatment plan for her in order to change and improve her smile. And as you can see, we completed a diagnosis which also included some gingival recession in the anterior area. Her biotype, gingival biotype, is very thin. So we tried to explain her that the best thing to do was to complete gingival surgery to cover the root before placing some porcelain veneers. So we were able to let her accept this treatment, and at the end of the story, we started with, the surgical, with some envelope flap and papilla preservation technique in order to cover the root. And this is the result after 2 weeks. And then we waited for like 3 to 4 months before starting the preparation in order to make sure that the maturation of the thin biotype, gingival biotype, could be achieved. These are my homemade temporaries, this acrylic composite, and these are the before and after temporaries. Okay? It's very important to cover the root not only for an aesthetic reason, but also because we want to bond our porcelain veneer to enamel in order to have a more reliable bond. And this is the isolation technique that we need to have. Why it's so important? Okay, this is the real isolation with rubber dam. Because, especially with thin biotype, I want to make sure that I can clean the resin cement at the gingival area in order to make sure that we do not have inflammation of the gingiva. So now we can complete the bonding of the porcelain veneers. I like to place all of the porcelain veneers together, and this is the final result. So the before and after pictures. It's not advancing. Okay, oh, it is. Okay, so once again, the lateral view and her final happy smile. As you can see, the position of the upper lip matches perfectly the gingival line. So before and after, once again. Let me try to change the remote control. to see if I can advance the slides. Okay, it's very slow. Okay, this is another case. Actually, this is a video. This is just a demonstration that we can achieve a minimally invasive treatment through a ortho-perio implant approach. Okay, so we are preparing the case with the ortho first in order to place an implant on the missing lateral incisor, and then we can use minimally invasive feldspathic ceramic. So this is the east coast of Sardinia. So we are jumping on to another section regarding biomimetic dentistry, and this is what I call the perio-biomimetic approach for class 5 lesion. And you can see here that this is something that I have been doing for a long time, and I'm starting getting some medium term recall at 5 years with tissue that are very stable. So we are going to present this protocol in Chicago in 2 weeks. And as you can see here, we have some problems because the length of this premolar is, the crown length is not the real one, because it's at the same line of both the canine and molar, and we have some problem on the molar too. So our approach is to re-establish with direct composite the original cementum enamel junction and complete the composite restoration first, which will be our guide in order for the tissue to heal at the right level. So this is what we usually do. We try to remove all the existing restoration, and you can see now the defects. So we go ahead with the isolation once again. We complete our composite restoration, and then the same day we start the surgical procedure. And as you can see here, I was not able to remove all of the composite that was placed by the dentist in the past, because here is an invasion of the biological width. So we did complete some kind of root planning here. We did condition the root, and then we reposition the gingival tissue at the level of the tissue that I did decide with my composite restoration. So this is a biomimetic approach in order to re-establish the original anatomy of both the tooth and the gingiva. Okay. So this is another video, another case that I would like to show you. We can remove the existing restoration, then we can sandblast before placing a rubber dam, completing the isolation of the field, and go ahead with the direct composite restoration on the cervical area. Same principle that we have done before. Here is some chlorhexidine on dentin before bonding. And then we can place some composite in order to re-establish the correct contour on the cervical area and re-establish the DJ. Now I can either polish or finish in the composite restoration, and once these steps, restorative steps, are completed, the same day I'm able to complete my surgical procedure in order to reposition the tissue, the gingival tissue, at the right level where I want them to be placed. Okay? So you complete the surgery with some release of the muscular tissue, and then you complete some sling sutures in order to reposition the tissues at the right place. Okay, so this is the final result just after the surgery, and this is the final result after the healing was completed. So you can have some more information on my website and some more videos too. So let's move on. Actually, it is in the northeast coast of Sardinia. This is the island of Budelli. And let's go ahead with the stress-reduced direct posterior composite, okay? Let's go ahead to understand the biomimetic technique that we can use to restore these teeth in the posterior area. We can use either a semi-direct and indirect technique matched with the immediate dentin sealing, or you can use the stress-reducing direct composite protocol. And today I'm focusing mainly on this part. This is the protocol that I introduced back in 2002. So you know that when you have some composite, direct composite material, you need to deal with the stress from polymerization shrinkage, which is responsible for a lot of problems and that you are for sure aware of. So this problem needs to be avoided if we want to predictably perform a restoration in the posterior area. So this is just a summary of all the problems that we can have if restoration is not done in the right way. So when I started putting together the protocol, I realized that the stress from polymerization shrinkage was depending on these 4 factors. So if I was able to control this factor, I was also able to reduce the stress from polymerization shrinkage. So let's have a look at the clinical cases and the clinical studies. And if we have a look at the ADA recommendation for direct posterior restoration, you see that they are very limited, but it's also true that they are date back to 1998. So I believe we need to review this recommendation. And we can have a look at the literature on clinical studies, and you see that this meta-analysis coming from Germany shows that direct composite do match pretty well regarding the performance with both amalgam and composite inlay. Keep in mind that these data are referred to restoration that were placed in the 80s and 90s when the composite restoration and the adhesive were not performing as well as the one that we have available today. In the literature, you can find some contradictory data. So that's why you need to select one protocol. You need to select one protocol that can be reliable in order to achieve a good result, and maybe use this protocol also for very challenging cases. So these are some studies. One is was completed by myself, and it's about the direct cuspal coverage restoration with stress-reduced composite, and we did not experience any fracture, any post-op sensitivity, and any recurrent decay with 100% restoration retention. So stress-reduced direct composite restoration can be a very good alternative to some more aggressive treatment. This is a clinical study that was published in the Operative Dentistry Journal with 100% success for this kind of restoration. And if you get, after 3 years, no marginal discoloration and deterioration, then you expect your restoration to last long, in the long term. And the good thing of composites is that you can repair them. This is a paper from my friend Jack Ferracane from Oregon, and he's a bioengineer, and what he says that the importance of clinical studies is very, very high comparing to in vitro studies. So what we need to look is the clinical success of dental composite over time. What are the drawbacks of composite? They are very well known. Composite wear may be if you do not control the occlusion well, bonding to dentin, if you do not perform a good bonding, stress from polymerization shrinkage, if you don't use a stress-reduced protocol, and the technique sensitivity. That's why, for many years, clinicians have been waiting for further material technology improvement from a manufacturer side, but no one has never introduced a step-by-step protocol that can guide the clinician to achieve a good result and maintain this result over time. So these are the 6 steps that I did introduce you earlier, and these are the steps that I always follow when I'm performing a biomimetic restoration. Let's start with the design of the restoration, because now you are not just placing a filling, you are designing a restoration in the same way that engineers are making their design. And you may have different scenarios, clinical scenarios. Sometimes you have a lot of tooth structure comparing to composite, and these the easiest restoration because you have the shielding effect of the remain sound tooth structure. The problem is when you lose a lot of tooth structure and you have mainly composite resin. Okay, so we are going to go through that part. So this is a minimally invasive preparation for these teeth, which were completed in the same appointment, using the stress-reduced protocol, but sometimes you have some more complex restoration. And you start with the occlusion, and you see that this restoration here is not functioning at all. So you go ahead with your protocol, step-by-step protocol, you prepare the cavity, you complete your caries removal endpoint, trying to preserve the vitality of the tooth. And then you start building up the proximal surface first in order to have a maturation of the dentin bond. Okay? And as you can see, I was able to switch from a circular to a sectional matrix without any bleeding. And you will see the reason why I was able to do that. Then you go ahead with the dentin buildup using very small increment in order to reduce this factor and the stress from polymerization shrinkage. And same thing on the occlusal surface in order to achieve this final result. And of course, the final step is the control of the occlusion in order to have now the verticalization of the occlusion with a centric stop that can help to distribute the load and the stress from the occlusion over time. One of the basic steps when I did complete this restoration, this final result, you can see that we have some invasion of the biological width, was to complete a minimally invasive crown lengthening procedure just in the proximal area in order to allow then the isolation of the field. This is key in order to place the rubber dam and perform a reliable restoration. So you need to take care of the gingival tissue first. So a stress-reducing protocol protects the restoration from both the stress from polymerization shrinkage and occlusal load. You need to accurately preserve and prepare the remaining sound tooth structure, both enamel and dentin. You need to use some strategy to prevent the degradation of the hybrid layer over time. And you need to adopt some specific layering and curing technique in order to eliminate the stress. And let's go now north. This is the northwest coast of Sardinia. This is called Stintino. And let's open another subject, the restoration of structurally compromised teeth. Okay? What we can do with these teeth? What's the ideal treatment plan? Can we perform a stress-reduced direct composite restoration even when we have a similar situation? Can we preserve all the remaining sound tooth structure? This is the question that we have to do. Now, you need to be aware that when we have large composite restorations, your design needs to change a little bit, because now you have a lot of composite material, and you have just not enough tooth structure to allow a complete shielding effect of the tooth. So the tooth is not able to protect the tooth restoration complex anymore. So we need to help the tooth to resist fatigue, dynamic loading, parent function, and trauma. Okay? Because these are teeth that already have been subjected to all of these forces. So when you place a larger restoration, you need to keep in mind that we have a Poisson effect. What does it mean? It does mean that when a solid, like composite, is compressed on one side, then you have some expansion on the other side. And the dentin is not able to resist tensile forces, so that at one point you may have a catastrophic failure. Okay? And then you need maybe to place an implant. So we wanted to avoid that. We wanted to keep our tooth as much as possible. So this is the answer. The rebound polyethylene fibers are able to absorb the stress, and they can allow a damage tolerance of the tooth restoration complex. And if a fail will occur, this will be a fail-safe. That means it will be not below the gingiva level, but it will be above the gingiva. So you can still repair your restoration. And this is just the schematic representation of a fail-safe and a catastrophic failure. So we have a lot of literature regarding the use of the rebound and the reinforcing effect of this material on the tooth structure. It's coming from both Turkey, United States, and Germany. So you can have a look at the literature if you want. You can see the data of the reinforcement effect of the fibers and the capacity of reducing the intercuspal width when you place direct composite restoration. And of course, the laid down protocol is very important, and it depends on many factors, including the occlusion, of course, the cavity design, and the thickness of the remaining tooth structure. So we call it wallpapering of fibers. That means we try to protect the remaining sound tooth structure in order for the rebound to absorb the stress from both polymerization shrinkage and occlusal load. So the 6 steps that you saw before, steps 1 to 3, deal with risk factors analysis. That means risk assessment. Step 4 to 7, because we add the use of a rebound. That's why you have one more step. Deal with material design and the stress reduction through stress redistribution and energy absorption. So you may have different clinical scenario, like a risk assessment which is low, and I would like to show you a case that was completed by using the fiber reinforced stress reduced composite. So this is the pre-op picture of a tooth that is very structurally compromised, but still we have some tooth structure remaining. So this is the cavity preparation. So we are placing some chlorhexidine. We are building up the periphery of the tooth first in order to allow a maturation of the dentin bond over time. And then we place the wallpapering, the double C wallpapering, in order to protect both the remaining sound tooth structure and the composite build-up from failure over time. So this is the final result, and once again, we follow all the steps, and this is the final occlusion result. So this is another short video that allow you to have a better idea of what we can do with a fiber reinforced composite. As you can see, this is a structurally compromised tooth, but according to me, the risk factor here is still low. So we go ahead with the etching, bonding steps. So we build up the periphery of the tooth first, dentin and enamel. We switch from the circular matrix to the sectional matrix, and we build up also the lingual surface. As you can see, I use very small increments of a composite to reduce the stress, and then I'm able to place some fibers in order to protect the sound to structure, remain sound to structure, and the composite build-up. So you go step by step, layer after layer, for both the dentin and enamel layers, and the final result is the restoration of tooth that was structurally compromised. These are some characterization tints which represent like my GPS for the build-up of the occlusal surface. So step by step, we were able to achieve the final result. Polishing and finishing, of course, are always very important, and this is the final result. And we are getting, again, result over 5 years with a very predictable result. So if we can maintain the restoration as these ones after 5 years, we expect this restoration to last in the long term. So now, if we have those structurally compromised teeth that are biomimetically restored, these teeth can resist fatigue, dynamic loading, parafunction, and trauma, of course. Let's now dive in the dangerous areas. The risk assessment now is very high, and I'm referring to teeth that have been fractured with a fracture line below the CJ. These are also called the hopeless teeth. Okay? So what we can do usually is designing, again, the restoration because now the remaining sound to structure is dramatically reduced. So what if a patient is coming to your office and you have a similar situation with a fracture of the facial cusp, and you have this fracture going below the CJ? We are going to perform some minimally invasive periodontal procedures, some root planing. We allow the tissue to heal, and then we perform our fiber reinforced composite restoration by placing the fibers according to the protocol that I showed you earlier. So this is the final result for both first and second premolars. These are the X-ray, pre-op and post-op X-ray, and as you can see from the final pictures, we started with this situation, and we end up with this clinical scenario. And if you have a look at the final restoration, you will see that we are able to achieve a good result. And if you look at the gingival level now on this premolar with the fracture comparing to the initial situation, we actually were able to achieve a better match of the gingival level. The same patient had fracture because of fainting also of the lower teeth. So in this case, as it was vital, I was able to reattach the fragment in place the same day that I performed the crown lengthening procedure in this area. So now this is another catastrophic, hopeless failure, according to many people, but as you can see, sometimes you can manage the gingival tissue and the bone surrounding in order to get some tissue available to place a matrix and isolate the tooth. And you can complete a fiber reinforced stress reduced restoration, minimally invasive, by placing multiple fibers on both the walls and underneath the occlusal surface. So we can achieve a similar result so that the tooth can function well over time. So we were able to preserve all the remaining sound tooth structure and avoid more aggressive restoration. So you have a full mouth rehabilitation with direct composite restorations that can be completed. This patient actually had different problems, and the most important problem is the TMD. So we try to take care of the TMD first. We try to find the right position, 3D position of her mandible before completing some kind of initial mock-up and walks up. As you can see, she has also a PFM crown on an implant. This is the clinical scenario that you can see. These are all the pre-op pictures, and you can see the severe wear on the posterior teeth. So we were able to find the right position of the mandible, and I did take this jig in order to complete my initial mock-up and the walks up. So all these restorations were stress-reduced direct composite restoration that were placed according to the protocol that I showed you before. Step by step, I was able to build up the teeth on the upper and lower posterior quadrants. So I was able to change the shape of this second molar into a first molar, and the third molar into a second molar. Same thing on the other side. These are multiple stress-reduced direct composite restoration, and I did also remove the PFM crown, and I did complete a direct composite restoration made by myself in order to have a similar wear pattern between the upper and lower teeth. So I did complete also the additive veneers, composite veneers in the upper and lower teeth in order to achieve this final result. So this is the full mouth rehabilitation, the close-up view of the upper and lower teeth, the lateral view, the occlusal surface view of both the lower and left, lower and upper teeth, and the final epismile of the patient. So daily pace protocol makes dentistry fantastic. This is what I like to say. And my conclusions are the following. Please keep in mind that we need to do everything is in our hands in order to preserve the sound tooth structure and maintain the tooth. Implants do work well, but they do not have the same blood supply, and also implants may have problem over time. The papilla management problem is very, very important, as well as the papilla high, as we saw this morning. And in conclusion, I like to stress again the importance to maintain all the remaining sound tooth structure, even in the worst clinical scenario when you have the kind of hopeless dentition. So thank you very much for your kind attention.